First of all, ladies and gentlemen, good evening. Thanks for joining our Monday afternoon webinar. See that you're all coming in one by one, which is very good. I am, in the meanwhile, brief introduction of myself. I am Beppe Perale, CEO and founder of IBI. And with us, we have today also Dr. Risebury from UK. In the meanwhile, I'm just, sharing a quote which I particularly and personally like a lot, as some of you know, I'm also background as a pilot back in the years, and I've always been hearing this quote. It's very nice. If a mile of road will take you a mile of runway can take you anywhere. So given what we are discussing today, we would say, what if we have a smart webinar could take us even further? So this said, and beside jokes, I think that we can start our SmartBone Monday evening webinar. So ladies and gentlemen, again, welcome. I'm pleased to have so many of you online. And I'm, again, would like to quickly introduce myself. I'm Giuseppe, known as Pepe Perale, one of the founders of IBI and currently the CEO. I'm very pleased to introduce you briefly our company and above all our product, our bone graft SmartBone, and then give the floor to Dr. Risebury, who will bring you really on what his experience is on using our bone graft. Very quickly, who we are. We are a Swiss-based medtech company with a very clear and precise focus, which is develop solutions for regenerative medicine, which are nature-inspired. By nature-inspired, it means that we focus on solutions that help healing bone tissues rather than not just simply repairing them. And we have literally invented, developed, manufacture and sell all over the world SmartBone. What is SmartBone? Is the next generation of a xenohybrid bone graft, which is exactly meant and thought to be used in bone reconstructive surgeries. We consider it to be the state of art in reconstructive surgeries. And actually, we have been building up more than 170,000 patients so far in our history, counting at least 18 scientific and clinical cooperation. Actually, this number is growing almost on a monthly basis now as we are expanding our operation in more than 30 countries worldwide. And we have direct publication and also publication by our customers from literally China to Egypt, UK, Italy, the rest of the world, more than 100. And we have been running directly 10 clinical studies. What is a SmartBone? So let me dig in a little bit more, rather than into our company, but into what we have developed. SmartBone is actually a family of products. They're all the same, differing in terms of shapes and sizes, but the basic concept, it is an advanced bone graft that serves the reconstructive surgery in the dental and oral maxillary space, in the entire orthopedic field, including traumatology, oncology, elective surgery, and we also have a line dedicated to custom-made bone graft. The technology material is, of course, always exactly the same. And what it's made of is what I would like to stress before giving the e-floor and the web floor to Mike, is the composition, because all the macroscopic properties of our bone graft rely on its microscopic structure. It is a xenohybrid bioactive material. What does it mean? It means that it has one nature-derived soul with synthetic components. The key part is a bovine-derived mineral matrix, which is obtained from adult bovine animals in a rigidly BSE-free context. And this ensures the component, which is the mineral matrix and the porosity of the system. To make it tougher, stronger, and to support regeneration, we reinforce this mineral matrix with biodegradable polymers. What are biodegradable polymers? Long story short, those of the resorbable sutures, being available on the market and in clinical use ever since at least 4 decades. And then this, on our proprietary recipe, we add some spicy on top. And the spicy on top, which gives the super flavor to our material, is collagen fragments. They are derived from porcine-derived gelatin, and they represent the final coating of our composite material, and they support and enhance the cell ingrowth from the patient into the graft. And finally, they spark the remodeling process. As you can imagine, this is a class 3 medical device, which is meant to be used in all type of bone regenerative surgery. And we have 4 major claims. The first one, let me say, it's almost quite obvious. It is extremely highly biocompatible. We have an entire quality system that ensures the best possible available source of raw material in the entire process. Second thing, as was underlined just before, the presence of the collagen promotes the cell colonization inside the graft. And the fact that this structure is made of polymers and collagen fragments makes the entire bone graft extremely hydrophilic, which means that it soaks up blood very quickly. And you know that blood is the vehicle of life and carries in, the blood clots, which releases factors, which then call up for stromal stem cells from the circulatory torrent into the bone graft. And ultimately, they are the kicking and starting part of the remodeling process. Last but not least, we are talking about bones, the scaffolding of our body. Our material has a very high mechanical performance, and it is very tenacious to screws, and it withstands aggressive surgical maneuvers. All these things together allow you, meaning you, the final user in surgeon's hands, to deal with what is so-called, let me play a little bit my academic role, the pentagon of the regenerative medicine. You need a very good osteoconductive scaffold. You need vascularization from the body coming in. You need the osteogenic cells from the patient. You need a mechanical, rough, substantial, tough environment. And then finally, the growth factors that are brought in by the healthy bone of the receiving side. Altogether, these things, we have very, very precise claims that I would like to leave you as a take-home message. The high mechanical performances mean that you get high volumetric stability and you can really work hard on the material with no fear. These, together with the unique biological characteristics, the open and interconnected porosities, meaning that the cells can go in any part deep into the graft, the high hydrophilicity will support the complete remodeling, and all together would give you 2 essential things: a reliable long-term results and the fact that you can predict the clinical outcomes. But of course, everything I'm saying, everything I'm telling you is based on our clinical experience and all the clinical investigations and studies we have been running in the recent year. And I'm just showing you something very basic, nothing exciting, nothing sexy, let me say. Tibial plateau traumatic injury. You see here the position of a wedge of SmartBone. The material is very regular when it comes out of our company. So it's a sort of dense, spongy bone. Once you graft it, it has no specific indication in terms of positioning and in terms of preferential ways of putting it, because it's really homogeneous. Once you graft it, for example, in such a situation and wait 5 months, you can see from an X-ray that something is happening. But if you want to do real regenerative medicine, you need to run a CT scan. And the day you run a CT scan, you get a 3D image of what is happening, you will see something extremely interesting. The homogeneous material has changed its density over time, and it underwent a very precise anatomically selective remodeling, meaning that the internal part of SmartBone has remained a little bit more spongy, while the external part has been heavily remodeled into cortical bone. And this is something that we have published out of clinical investigation with it, and typically comes out of the autologous patient's bone behavior. It's very important because this happens not only when you use the big blocks that we have, but this happens also when you run, as in this case, with granulates inside specific cavities. Again, after a certain amount of months, which varies, of course, in relation to sizes, age, and gender of the patient, that you can see clearly that the remodeling process is rebuilding the natural local architecture of the bone. But let me finish before handing over this virtual stage to Mike. 2 important things. As I think you all know very well, making bone regenerative surgery means dealing with the patient, and the patient general condition must be carefully evaluated. There must be a treatment plan, And some key elements must be strictly considered. The first are the overall condition. Second is the blood levels of vitamin D, which is an essential promoter of bone regeneration, and then the control of the cholesterol level. Impaired cholesterol level will impair the bone regeneration. Last item, given the complex structure of our material, we always underline that our material can be pre-soaked in patient blood, but definitely not in saline solution, as the saline solution will impair the intimate microstructure of the material and can lead to failure or poor clinical result. Let me finish saying that if you are following us, you will see that regularly every year we make publication of our clinical studies, clinical experiences, case series, which also spread into very complex areas such as, for example, pediatric orthopedic oncology on one end, or the management of infected cases which were treated with different material. I strongly suggest you to read our literature, to come up with questions, but to be very cautious when approaching very complex cases, because we suggest them to deal them on a progressive experience base. And of course, as we are here now today, follow our webinars, get in touch with us and learn, as we are now doing with Mike, from the real experience of other colleagues using our material. Thank you very much. And as I say, let's keep our mind, young as we were playing Legos. Mike, the floor is all yours. And I'll mute and hide myself.
Well, hi everyone. Good afternoon, good evening. Can you all hear me? So I'd like to share with you some of the experiences of specifically high tibial osteotomy surgery here in Basingstoke in the UK. Also, specifically our use of bone graft, and more recently the use of SmartBone graft. So thanks very much, Beppe. You've heard a lot about the basic science and the unique xeno-hybrid nature of SmartBone there, and we'll get into that a bit more later. I'm obviously a knee surgeon. For those of you who don't know, we work in Basingstoke in the south of the UK in Hampshire. We're a centre of excellence, a referral centre for osteotomy surgery around the knee. A large proportion of that is high tibial osteotomy, and that's what I'm going to focus on today. So just some basics first, and I apologize if this is revision for the knee surgeons amongst you. This is an important slide, a slide I've stolen from my friend and colleague Roman Seil, ex-president of ESCA, based out of Luxembourg. I think, as Beppe said there, it's very important to try and stay in the green zone. And what I mean by that, and you can see from this excellent slide, is regeneration and repair rather than bailing out to reconstruction and potentially salvage reconstruction. So as I said, we're going to speak about HTO, we're going to speak about SmartBone and our use of allograft and also SmartBone graft in Basingstoke, specifically for opening wedge HTOs. We're a referral centre in the UK, so we do high volume of osteotomy surgery around the knee. Just to recap some basics here, regeneration and repair is very important. The teaching of the 1980s and possibly 90s was very much arthroplasty and knee replacement based. And in its place, obviously, knee replacement's a good operation, but for a large majority of patients, particularly those who are younger or middle-aged, restoring your own knee is super important, and osteotomy plays a large role in that, and it's something we do a lot of here in Basingstoke. So let's not forget the basics. Alignment is the key. It's super important. We shouldn't just be replacing arthritic knees with metal and plastic. Knee replacement, yes, is for arthritis, but let's not forget about the alignment. So this is important. If you look at every algorithm, the alignment will come top, and this is in order of its importance. So, for example, in the 1990s, there was lots of work done on joint surface work and cartilage work, and much of it ignored the alignment. So there is finally a resurgence in osteotomy surgery, something that we've been realizing for 2 or 3 decades in our own practice. So obviously that alignment is both coronal and sagittal. Primarily we're going to talk about coronal today, but sagittal is important as well, and also rotational, particularly when talking about the patellofemoral joint. So ligament stability is the next most important thing, followed by the meniscus, followed by the joint surface. And of course, that all works in synergy. Okay, osteotomy around the knee isn't just for moderate or severe arthritis with mild malalignment. It's more than that. It can unload or offload damaged compartments, as it does in a varus knee with an HTO, but also for deformity correction, either congenital deformity, growth deformity, or post-traumatic deformity. It can be used to improve knee kinematics, both coronal and sagittal alignment, and rotational. Improve the stability of the knee. Let's not forget the importance of the slope and how powerful that is in the ACL, PCL deficient knee. Also to reduce pain, and I'm always amazed, even in severe medial OA, how an opening wedge HTO, even to neutral, can completely get rid of their pain. And this is something to do with the work of Scott Dye and restoring homeostasis in the knee. It can also slow or even prevent deterioration. So early intervention, which we're doing more and more, may even prevent arthritis developing. So we're quite keen on early intervention and maintaining your own knee. It can help retension ligaments, support ligament surgery. A common operation for me would be a chronic ACL deficient knee with early or moderate medial OA. And so a common combination would be an opening wedge HTO, respecting the slope, combining it with an ACL reconstruction. And of course, you may use it to protect or offload a meniscal transplant or meniscal root repair, or indeed in the chondral surgery like we discussed. So the options are varied. I've started with the 2 most common, which would be for us a medial opening wedge high tibial osteotomy, which is the workhorse for varus. This is what we're going to focus on today, but we'd also do a medial closing wedge distal femoral osteotomy, particularly for valgus. More and more, and I think it's probably 10 or 15% in our practice now, we're considering a double level osteotomy, i.e. the femur and the tibia, respecting the joint line obliquity. And that's all to do with planning, which is beyond the scope of this talk. And as I said earlier, don't forget the power of the slope, particularly in a PCL knee, even in ACL knees. Reducing the slope is very important, potentially, particularly in revision surgery. And as I've said, combined osteotomy ligament surgery. The rotational stuff, which we do a lot of in Basingstoke, is primarily for malalignment and for patellofemoral problems. More and more, and you saw in Bepe's slide there, a tibial plateau treated beautifully with SmartBone in the defect beneath the plateau. We're doing osteotomy or complex osteotomy for post-trauma, and this is often a plateau fracture that's either been maltreated or has malunited. More and more, we're doing 3D planning for these, and it's really very powerful to correct the coronal and sagittal alignment. And the use of bone graft or bone substitute for these is really critical. And occasionally revision osteotomy for when it's gone wrong in the first place, thankfully mainly from other centres, I have to say. There's no perfection in knee surgery or any other form of surgery, but you must be looking for accuracy and precision, and we'll talk more about that, because our use of bone graft in Basingstoke is more for accuracy and precision rather than bone healing. Okay, so more and more we recognize the importance of the precise planning. So you need good imaging, and that's long leg alignment films, potentially plus CT scans if you're doing 3D planning, and then of course precise surgical execution. And if you're not using navigation or robotics, which we don't, you could use PSI instrumentation and 3D planning. We use that for more complex cases. But for the more routine 2-dimensional or simpler osteotomies, particularly HTOs, 2-dimensional good planning is enough, but using something to get that precision. And for us, that something is an allograft wedge or a SmartBone wedge. So indications are important. Choose your patients widely. The ideal patient might be quite young. My definition of young is largely based around my own age, and so that's getting older and older. I used to think a 52-year-old was ancient and needed a knee replacement. Now I would definitely be thinking about regenerative surgery and osteotomy surgery in most people of that age. Think about the patient expectations, talk them through the rehab, and obviously think about comorbidities. As I said, the image quality and planning is the absolute key. There's no point in just going ahead with osteotomy surgery based on poor imaging, and that's another talk for another day. But good quality, preferably calibrated long leg alignment films are critical, and that means you can plan preoperatively and know exactly the millimeter of wedge base you're requiring, and also the trapezoidal nature of your bone wedge, which we'll get into. The other thing is then executing that properly. And as I say, I've planned here an osteotomy of 6.8 millimeters, which is quite typical for us, but quite small for those doing less HTO surgery. Trying to reproduce that and accurately fix that, particularly with a generic plate, is quite difficult. And it's very easy to lose or change your correction while you're trying to fix it. If you fill the gap with a structurally sound graft, such as an allograft or a SmartBone wedge, clearly you're going to end up with that precise correction, and that's the main reason I would use it. Okay, and I'll go on about the other reasons later. The other thing that's important for us as a group is being able to follow up the patients properly, and that's increasingly difficult in the NHS. And being able to collect data and have a research group so we can actually publish our results. We're very proud in Basingstoke over the last 2 decades of our osteotomy work in particular, but recently our fellow Ahmed Mabrouk has published, I believe, the largest published series of HTOs in the world, and this has been presented both in the Kista journal aligned with ESCA and also at the last ISAKOS meeting in Munich. So we have 13-year follow-up, and it's over 650 patients with good results. So I would encourage you to look up that paper. We've done some numerous spin-off papers from that. For example, looking at the body mass index. Here in the UK and probably in other parts of Europe and certainly the US and North America, patients don't follow ideal BMIs, and actually our average BMI is over 30. What Ahmed was capable of showing through our series, and it's what I've seen in my clinical practice, is the BMI actually made no difference, and done well and executed well, it made no difference. In fact, the heavier patients did better because their starting point was lower. The other thing, there's a bit of a myth around HTO surgery that it doesn't work in grade 3 Kellgren-Lawrence and grade 4 Kellgren-Lawrence. Our own clinical experience and data would suggest exactly the opposite. More than half of our patients, I believe, are in grade 3 and 4, and they do just as well, if not better again, than the lower grade patients. So don't exclude people because they're bone on bone. They're often the best patients, particularly if they're slightly younger, slightly fitter, and they have varus deformity. So just a compliments to my colleague Ahmed. He's started a consultant job here in Devon, in Exeter, who'd put a lot of work in to publish our database. So filling the gap in high tibial osteotomy, that's what we're talking about today. Do you need to? Should we fill the gap? Well, very controversially for this talk, I would say no, you don't need to fill the gap. With a fixed angle stable device in good bone and an intact hinge, the gap doesn't need to be filled. And more than the first half of our series, certainly historically, we had nearly 100% uniting with no bone graft in the gap. The problem with that, as I said, is more the accuracy intraoperatively and the accuracy postoperatively, particularly when you're using generic plates and particularly in smaller corrections. The other thing which I haven't mentioned yet, which is really important, which we noticed when we started using particularly allograft more than a decade ago, and we now routinely use it, is that patients get much less bleeding, pain, and swelling following the use of an allograft. It's a bit like a cork in a bottle, stopping that early bleeding, particularly in an HTO, which can be debilitating. The other thing is, I believe it leads to a lot earlier pain relief, a lot less pain in the early weeks, earlier full weight bearing and therefore earlier recovery, and certainly they're healing quicker when we assess the x-rays and scans. That's something that SmartBone excites me, because they could potentially heal even quicker with SmartBone, and that's what I'm seeing in my early cases. So what are the advantages then? It's the precision that's the key, the early stability, so you're not relying on an overly constructed, overly strong plate. You get less bleeding, swelling and pain, and potentially a quicker recovery. I'd also say there's slightly less concern with regard to hinge fracture. I'm not saying you shouldn't be concerned, because you should, but if you have a small hinge fracture, particularly a type 1 Takeuchi, but you've filled the gap, actually there's probably going to be little difference in the recovery. And generally speaking, in HTOs, I will not ignore a hinge fracture, but will keep an eye on it. And I have to say, I've never had to go back in for a lateral hinge fracture in an HTO patient, particularly with the use of graft. So what do you fill the graft with? As I've said, in Basingstoke, our go-to has been an allograft. You can get that as a pre-made bone wedge. The problem with a pre-made bone wedge is that it's symmetrical. And for most HTOs, it needs to be asymmetrical, i.e. trapezoidal. And what I mean by that is a wedge base at the posteromedial edge bigger than that at the anteromedial, which will give you a maintenance of the slope. So we don't like pre-made wedges ourselves. We use a full femoral head, and we make custom bespoke wedges at the time of surgery. And I'll show you how we do that in a minute. You could use bone chips. Bone chips or putty, which is pliable, are probably better in my experience for plateau fractures, but in the trauma setting. But in HTOs, they don't provide that structural stability as much. They're good for gap filling, but not as good for the structural stability. So I personally would use an allograft or SmartBone wedge. Synthetic substitutes I wouldn't recommend. One of the main reasons our early series, which was largely with Tomofix plates, didn't use graft is that when Tomofix first came out in the early noughties, the company sold a beta tricalcium phosphate wedge that came with it at great expense, and in our experience did not incorporate with the bone. And I've revised osteotomies done by my predecessor after many years to knee replacements, and that chalky substance is still in the gap, so we wouldn't recommend that. SmartBone, which we're now going to go on to talk about in detail, has many potential advantages over all of this, of course, because it's off the shelf. It doesn't need to be fresh frozen. It doesn't need to be catalogued and stored and transported. It is there on the shelf, and therefore, especially for a lot of places where allograft isn't available, is a particular advantage. So we're using it as a backup, but also using it more and more because I like the way that it handles. In Basingstoke, as I said, we've used the fresh frozen allograft. It gives you that accuracy, early post-op stability, but also very importantly, is intra-operative stability. So during the operation, making it safer and easier. Those of you who do HTO surgery, and certainly those who are starting or are doing it in bigger patients like I often have to, will find that maintaining that gap using just a laminar spreader or something similar is nigh on impossible, and often the laminar spreader will pop out when you're trying to fix the plate on, etc., etc. So the key to the operation is getting that accurate correction. So popping an allograft in or a SmartBone wedge that is perfect makes the operation much, much easier, and the stability provided by that is huge. You can often move the leg around before you even put the plate on, and it feels great. So as I said, less bleeding and swelling and pain. But yes, it does require an assistant, which is where the pre-made wedges are attractive. I'd just be mindful, if you have a symmetrical wedge, that you then chamfer it yourself to make it narrow at the front so you don't inadvertently increase the slope. Okay, so SmartBone could well be a good alternative. This is how I say we do it. We have two assistants, Dave Howard and Kinga Shashitska, who do this much more expertly than me, and this is them preparing one for us. So you can see a femoral head here. This is one of our early ones in Basingstoke that's retrieved from an arthritic patient. So that can be a problem and can potentially be another advantage of SmartBone is you're guaranteed the quality of that tissue. So sometimes, particularly when we're getting it from an arthritic patient rather than a cadaver, if you like, is the quality of that bone. Once it's cleaned, it can be good, but allograft can be quite brittle and can break apart, etc. Whereas with SmartBone, you have that stronger structural integrity to it. So you can see what's happened here, and you can see what I mean by the trapezoidal nature of the wedge. So this is the wedge base. Let's say in this case it's about 6 millimeters. Anteriorly it's only about 4, and that is to maintain the slope at the end of the procedure. This is a bigger wedge, and you can see that there the hinge is intact, the wedge is in place. I use a laminar spreader in the gap before we pop that in during surgery. My colleague Sam uses a Hinterman's with a couple of wires either side, leaves the gap free for you to pop the wedge in. SmartBone, I won't talk in detail about the structure because Bepe's covered that and he understands it far greater than me, but it comes in different size blocks. So far, we've generally used one of the bigger blocks so that we can fashion the wedge that we want. For the smaller corrections, that's a bit wasteful and you could probably use a smaller block. We are looking to use the wedges more and more because, for example, if you have a 7 millimeter wedge, 7 posteriorly, 5 anteriorly, we could use an 8 or 9 millimeter out of the packet wedge for that and just chamfer it accordingly. The only important measurement really is that at the wedge base to maintain the correction. The biodegradable polymers and the collagen gives this substance a very strong feel. Although it looks brittle like a bone graft, it doesn't break up and fracture like the bone graft. Often when we're trying to chamfer or pop in the allograft wedges, they can fracture and they are a bit brittle, so you need to be careful with them. Whereas with the SmartBone, it has a much stronger structural integrity to it, and we've all noticed this during its preparation in the surgeries. It seems to osteointegrate really well. This is highlighted here, so dust-free shaping. In other words, when you're cutting it, it doesn't fly off everywhere. It's quite easy to make a nice shape from it. And it comes, as I said, in all these different blocks, but also different wedges. And we're working to look at that. Maybe the future is if people use it more and more for HTOs, that we could develop wedges that are trapezoidal in nature to make it super easy for people to use. I'm going to present to you a couple of my early SmartBone cases, just to give you an idea of what it does for me and my HTOs. This case is a bilateral case. He's a typical patient for me. He's about 60. He's self-employed, runs his own business, very well motivated, quite sporty, ex-footballer. And you can see he has natural tibia vera. He's got quite severe medial arthritis, but he's very active and he definitely didn't want a knee replacement. And I definitely didn't want to do a total knee on him because of the limitations that would give him. Also for me, although I do partial knee replacements or medial unis very regularly, for me, he's too varus for that. And the problem with doing just a medial uni in him is you leave them in quite a lot of varus. And I do worry about early failure. So I think let's avoid an implant and we go for osteotomy surgery. So when we then ran the plans, the right side is on the cusp of me doing a single level. What I mean by that is once we've corrected to 50%, so bang down the middle, I'm not correcting into valgus here, I'm correcting more and more neutral as the years go on, 52%, 50%. This corrects it beautifully, but we are creating an MPTA, so a medial proximal tibial angle of 94 degrees, which is my upper maximum. If it's beyond that, we believe you're creating a secondary deformity, a joint line obliquity, and if the correction is above that, we're moving to a double level. So you can see here, his left side, which we're due to do, I believe, next month or the month after, is a double level. And this is quite a common operation for us. With severe varus, we're doing a medial opening wedge HTO of lower numbers and a lateral closing wedge DFO, and that's quite a common combination for me. This case we actually did for the live surgery at the last Basingstoke osteotomy masterclass, and we used SmartBone for the wedge. I used a PSI planning and implant only because that's what we were using for the course, and we use a SmartBone wedge. So this is some fluoroscopy during the case. And for those of you that are familiar, you can see I have a retractor in here protecting the posterior neurovascular structures. We have radiolucent ones, which are a bit better, nicer. And we use a precision saw, which is only 1.27 millimeters in diameter and only moves here, again, to minimize any risk to the neurovascular structures. And you can see me cutting towards the hinge point here. The jig in here, in this case, is a PSI polystyrene jig that's been made by BodyCAD. It's fixed in place with screws to make it secure. We can then open the osteotomy on that plastic jig rather than with laminar spreaders. And you can see here the SmartBone wedge fashioned by my colleague Kinger, which is perfect and fits beautifully into the gap. You can see here it's the same radiolucency as bone for obvious reasons, because it's primarily bovine bone. The reason it's lighter here is because we're using this bespoke plate with a little wedge to validate the accuracy. We had to cut a little wedge into the SmartBone, and interestingly, that proved very easy because of that non-brittle nature of the SmartBone, as I said. So that's the plate in place, and then this is with the plate fixed, and you can see the hinge intact and the bone graft beautifully in position. That's an oblique shot showing the posterior aspect of the osteotomy. And this is the day one post-op x-ray. Okay, so we'd always image them for a baseline day one. This is him at 6 weeks. He's a good patient, to be fair, but he was also very, very good, better than average in terms of his lack of pain, etc. They all use cryotherapy post-op, either a physio lab or game-ready type machine. And you can see we've corrected him to 50 as planned. There's his Mikulich. And there's our 2p piece for calibration. And you can see on the close-up of that the SmartBone wedge is already starting to integrate, and the thinner edge of the osteotomy is already looking like it's healing. His 3-month film, which I don't have on this presentation, is even better. So this is another case who, amazingly and by coincidence, we've just seen in my clinic this afternoon for his 6-week check. I think it's 7 weeks post-op. This is his case. So he had a double level, but the tibial side is quite a small correction. Because we've done a double level, despite the fact him having a Mikulich of about 5% preoperatively and being bone on bone Calgren Lawrence 4, both knees actually, we've done a double osteotomy with 7 or 8 millimeters opening, closing, on the femur, and only 6 millimeters on the tibia. It's 6 millimeters once we've added the saw blade thickness. And you can see from the planning, which we can talk about another time, that that's kept him within all the normal angles and created a nice straight knee with a flat joint line. Okay, so this is his case. This is non-PSI, so this is our standard technique in Basingstoke. Couple of 2.4 guide pins respecting the hinge position that you've planned. You can see here the guide pins, and you can see the saw blade, the precision saw, exactly at the hinge point there. And then we open the osteotomy sequentially in this case, in a non-PSI normal case, with sequential osteotomes, watching it open, checking the hinge hasn't fractured. And what I tend to do when we're putting a bone wedge in, which is actually 100% of the time now for us in Basingstoke, I'll open it about 1 millimeter more than the bone wedge so that the bone wedge slides in beautifully, and then we just close the osteotomy onto that SmartBone wedge. And you can see here we've slightly over chamfered it, but that really doesn't matter. This is the measurement that matters, which was exactly 4.5 in this guy's case. It was a tiny wedge, 4.5 plus the saw bones. It's actually the saw blade thickness, sorry. So it's actually just under 6 millimeters with an intact hinge. Okay. So this was him. This is the end of the fluoro. We've used a more standard traditional plate here. You can see on the lateral x-ray, day one post-op, the biplane nature of our osteotomy. So we do a little proximal biplane pretty much routinely, unless we're changing the slope deliberately. And that gives us more surface area healing, quicker healing time, more stability. There's lots of reasons why we do that. And then here you can see beautifully the SmartBone wedge filling that gap. Interestingly, can you see here the compression screw bending? And that's because as we're compressing it, the osteotomy, the plate's squeezing down and the osteotomy is squeezing against that bone wedge. And because it's a nice, tough, resilient SmartBone wedge, you won't lose correction by that. If you don't fill the gap, which is what we used to not do, as you tighten this screw, and particularly if you over tightened it, you can lose correction and actually squeeze your correction, which in a small correction like this is a disaster because you can lose 10-15% of your correction. So using a wedge is nice because you can squeeze the whole construct together. So in summary then, filling the gap in a medial opening wedge HTO is not necessary, but I would strongly recommend it because the benefits include precision and accuracy of the correction, both during the operation and post-operatively, which is clearly the key of this whole procedure. Also, we've noticed that you do get, on average, reduced bleeding, reduced swelling, and much reduced pain post-operatively, which is important. It gives you increased early stability regardless of the fixation plate you use, and potentially quicker healing with earlier full weight bearing. And I believe SmartBone is a good option, particularly for people where allograft is not available to them. I'd like to thank you very much, and I'd like to give a shameless advert to the Basingstoke Knee Osteotomy Masterclass, which is run by myself and my colleagues Sam Yassen, Adil Mumath, and more recently my new colleague John Palmer, with an excellent, esteemed international faculty. Our course this year is being run from the 2nd to the 4th of December and it's a 3-day course now, including everything you would care to know about osteotomy around the knee, with sawbone workshops, the use of SmartBone for those interested, and a cadaveric day, which we added last year for the first time, which was met with great success. So I thank you very much. And if anyone has any questions or debates, I'd be very happy to answer that for you.
So thank you very much, Mike. I think that this was absolutely astonishing and I would say crystal clear. And the purpose of this webinar was exactly this, to give to the colleagues online a real touch. Well, at least a digital touch, although a real touch would have been having the pleasure of being in person. And, getting the sense of what is the daily use from someone who has completely, fully, very perfectly understood what are the characteristics of SmartBone and can take the best out of it.
Thank you.
So again, my thank you to you and to the colleagues behind the scene of organized everything. And I think that if we now have any question, if you have any hands up, we are happy to take any question. Last very simple thing, I would ask you, Mike, to kindly interrupt sharing.
Okay, no problem.
Yeah, lovely.
Is that gone?
Yeah. Yes, sir. This is it.
Beppe, we have a question in the chat from Mr. Riaz. I don't know if you can see that. The question was, for everyone, this is Hamid from Sovereign Medical. Do you think the SmartBone increases the union time compared to allograft? That was the question that was asked by Mr. Riaz.
Is that from Oz Riaz?
Yeah.
Yep. Oh, hi, Oz. That's great. Thanks, mate. Yes is the short answer. Whether it reduces the healing time? Was that the question? Yeah. I think yes is the answer. Obviously, I don't have.
Sorry, Mike, it was union time. Apologies, it was union time.
Yeah, union time. So yes is the short answer. The interesting thing is, if you're using fixed angle devices such as TomoFix or the Biotech plate, which we use increasingly now, i.e. a strong internal X-fix, as I said, you get nearly 100% healing with no graft in the wedge, and that was our experience in Basingstoke. So the reason you'd say, well, why use graft? Well, as I said, those other reasons that I said, so they're more important to me than the healing time. But a lot of patients were slow to heal, particularly the older females, particularly the heavier patients, particularly if they had any risk factors such as smoking or whatever, low vitamin D. So I think definitely you're going to get quicker healing time. I think, and it's at the moment a subjective rather than a statistical objective finding, but you do see it in clinic when you do a lot of this stuff, that patients do seem happier quicker. That's my experience. And certainly looking at the 3-month x-rays with the non-grafted osteotomies, so no graft at all, I was often quite worried at 3 months. That just looked like no evidence of healing, and I was really worried. With allograft, you start to see healing, but the few SmartBones I've done, they seem to be healing quickly. And that's, I think, the experience of SmartBone in other areas of the body as well. Just moving on from that, I can see on the chat, because although I'm quite poor on technology, I have managed to open the chat. I can see that Oz asked about the trapezoidal wedge cutting as well, and I think that's right. And I think I covered that a bit in the talk, but didn't have time to go through it in detail. I think cutting the trapezoidal wedges is easy, both for you in theatre, but if you don't have that skill in theatre and you want a trapezoidal wedge out of the packet, I strongly believe that's something that the IBI guys would look at, because working with people like myself, this is what we're doing. We're trying to introduce it to this space. And if people adopt it a lot for osteotomy, I'm pretty sure they could produce trapezoidal wedges based on the fact that the anterior wedge is X% smaller than the posterior wedge. And that would, certainly with the lower volume surgeons, it would prevent them increasing the slope inadvertently. And I think that's what you're probably getting at there, because that's my concern, is lower volume surgeons, which, let's face it, will be most surgeons. That always is the case. If they're just putting a symmetrical wedge in, then they are creating an issue. So I think the availability of trapezoidal wedges moving forwards would be quite exciting, and it's something that I can look at with Beppe and the development team, I think.
Yep. So, well, I would like to thank Oz for this for the question, and you, of course, Mike, and also for having made a kind of a spoiler of of what we are working with, and I'm seeing also that was a very kind answer on the chat from Pregash, who is another user of SmartBone specifically in the HTO domain, and he very kindly answered, confirming exactly what you said. And this is one of the features of SmartBone. You have a material which is hard. At the same time, it means that you can work on it. Let me say it's hard on one end, and you can work it easily on the other. Meaning that is a typical hands-on by an orthopedic surgeon. That's exactly for what was the original purpose of the design of SmartBone. And then sure, about the shapes. As we are the manufacturer, we can go everything from the big blocks to the small granulates for the, for the dentist, for example. Yeah. And we are discussing with you some dedicated trapezoidal shape in order to get something like you turn yourself back and you get the shape you need.
Exactly. And one of the things, for example, what we've done in the past, I showed you that case we'd done with the PSI osteotomy. What we did for some of those cases is we, how we cut our femoral head allograft, as part of the PSI design, in addition to the jigs we used for the osteotomy, they designed a little jig that helped you cut the trapezoidal. So just a little plastic jig, but it helped you cut the trapezoidal bone wedge exactly as per the osteotomy. And there's no reason why you couldn't do the same, but just use a SmartBone block for that.
Yeah, and of course, if you see it from the manufacturer perspective, we have a wide range of SKUs. Typically in traumatology, you do not know what you get, and we have different sizes and different shapes. Exactly that you find the one that most fits what you need to make the fine tuning and the adaptation in theater on the surgical field.
Yeah.
On the other hand, the idea as we have today a palette of wedges, we could have a palette of trapezoidal wedges as well.
Yeah.
Nothing will change, but just in between commas, shape and dimension.
Yeah.
But of course, nothing in terms of material composition, properties, etc.
Excellent.
So thank you for having spoiled a little bit.
Sorry.
No, more than welcome and much appreciated, I guess, also by the others.
Oh, thanks, guys. I appreciate that. Oh, hi, Chris.
Hi, yeah, great to see you, and thank you so much. That was fascinating. Last time we worked together, I think it was on unicondylar knee, and
yes.
A lot of surgeons, I think, that's getting younger and younger.
Yep.
What would be your cutoff for osteotomy versus unicondylar knee?
It's a good question. Also, it's a bad question in that, and you might know the answer. I don't know, but you know the answer. But for Mark, the answer I'm going to give is I don't have one, right? So I think you have to be very careful talking about specific ages, and that isn't just because I'm getting older and we're all getting older. It's purely because I'd go back to that graph I had on the start of my talk when I finally shared it properly, about arthroplasty. Although a uni knee is a fantastic operation, I find I'm doing more and more later in my career. I think I'm a bit reticent doing any implant, particularly a partial knee replacement, in someone in their 40s or someone even in their 50s who's fit. But I think it's more than that. I think you have to look at the specific patient. So, for example, quite a lot of my older patients are men who've had trauma, often femoral fractures and things, and they're in their 60s and they've got really bad medial arthritis, but they're really varus, both in the femur and tibia and knee. And for me, they can't have a uni because they're too wonky, they're too varus, and therefore, because people are so arthroplasty trained, they start talking about total knee replacement, which for me in a patient that functional is crazy. And more I would be doing a double level osteotomy in that person with a view to either doing a uni or a total knee later. And what I've found is that less and less do they even want an arthroplasty, because pain isn't their major problem, it's the deformity. So I think treat the individual. If you've got that genuine overlap group, and it does exist, I think probably 5 to 10% of my patients with medial OA are kind of between 50 and 60-ish. They're not that varus. Most of their varus is in the knee itself or loss of joint space. I think you genuinely can choose either, and then I will have a conversation with the patient, because I have done osteotomies in 65-year-olds, 70-year-olds. Equally, I've done unis in 50-year-olds because I thought they're more suitable for that procedure. In all honesty, even those of us who do a lot of both, I honestly don't think we know the answer for some. And if I've got one of those patients who I think genuinely could do well with either, I'll put it to them. I'll put particularly the recovery to them, because a uni is obviously quicker to get over, and they'll sort of choose on that basis. Patients, once they understand it, will choose it. And I've had patients who've been booked for an osteotomy and have changed their mind to a uni at consent because they genuinely couldn't afford 3 months off their manual job or whatever. So I think you have to be careful with specific ages. If you speak to a uni protagonist who does no osteotomy, they may be happy putting unis in 39, 40-year-olds. In Basingstoke, we really aren't, and that would be really rare for me. And equally, a very fit 60-year-old who wants to run around, play tennis and ski may be better off with an osteotomy. So I think take the whole picture into perspective, really.
Sure.
Sorry, that was quite a long answer.
It was accurate. Thank you.
Someone here, Niv Bamber, who I know, thanks Niv, you've asked about correction, and he's talking about correcting to 50% like I did on that case. And the reason I did that is when we first started, or when Neil Thomas, my predecessor, first started, we were correcting kind of towards Fujisawa point, 60%, 58%. But more and more, those of us who do a lot of osteotomy are finding that we're dialing that back. And now I'm pretty much routinely aiming for 52%, maybe 55. There is an error within that. And I think if you've got a big deformity, like both of those patients I showed you, aiming for 50 is safer. patients hate valgus. Most patients hate valgus, but particularly varus patients hate valgus. So I think correct to 50, the old feeling that you had to really offload the compartment just hasn't been proven. And actually the correction doesn't seem to correlate with results. So we're correcting more and more to sort of 52%. If you end up slightly undercorrected, then that lends itself very well to doing a uni later. Even if you've corrected to 55 accurately, I'll be honest with you, most of those patients who then got converted to arthroplasty, and it's only about 6% in our whole series, get a uni. So I'm with Niv on that one, that I would definitely prefer a uni by far over a total. So part of my thinking is correcting to neutral or just beyond. So my next option would be a medial uni. Absolutely. So guys, I think, has anyone got any more questions or?
I'm checking through exactly. So again, you know, Mike, every of your answer was so precise, you know, neat and clean, much appreciated, I would say.
Thank you.
And yeah, it looks like that we don't have any hands up.
Stunned them into silence.
Any other students?
We're all students, Pepe, same as me.
Yeah, we are in our 20s, so that's perfectly fine.
Exactly.
20 plus.
Okay, well, thank you so much.
Yeah.
Thank you for allowing me to host that. I hope that's what you wanted. I'd be very happy if that stirred up some interest, and perhaps to present when we've done more and have some more data on the longer term results. I'd be very happy to do that for you guys. And as I said, I'm quite excited working with the SmartBone as part of what we're doing here in Basingstoke, as are my colleagues.
Yep. Yeah, well, thank you all, and also the participants that were online with us. And I would say, you know, that's a little bit of you know, another spoiler around. For sure, we will follow up in the midterm with, you know, also some publications together, which is something we really, really care about. So you know, stay tuned. Further webinars will come. You'll see our faces again online, and hopefully we're also arranging some kind of in-person event in UK in the coming months. So I think that with the precious support of Hamid on site, there will be chances also to meet all together eventually for some, you know, face-to-face discussion, and then why not a beer together. So thank you for everyone.
Thank you so much. Thanks, guys.
Have you all, relaxing evening.
Thank you again, Abi and Mike, for allowing us to have this space. Really appreciate it. And thank you for all the audience as well. We know it's getting late in our working days, but we really appreciate everyone's interaction. Thank you so much again.
Thanks, guys.
Oh, ciao, guys. Ladies and gentlemen, good evening then. Bye-bye.